You are welcome to my channel. Today I'll be talking about Dravet syndrome. Because this syndrome is very concerning, so many experts have worked on Dravet syndrome in the past and now. So going through the literature, you are likely going to find these under different names, given in the past, and some still use them in the present. So it could be severe myoclonic epilepsy of infancy or severe polymorphic epilepsy of infancy or borderline severe myoclonic epilepsy of infancy. And lastly, you can find Dravet syndrome as intractable childhood epilepsy with generalized tonic seizures. Dravet syndrome is a very rare epilepsy with a destructive type of prolonged seizures, triggered mostly by increase in temperature, and this will be starting in the first year of life. When it comes to the genetic link, it is an autosomal dominant genetic disorder. Maybe a non-hereditary genetic mutations, and that will be as the first case in the family. It's a severe form of epilepsy. Epidemiologically, like I said, Dravet syndrome is a severe form of epilepsy related to a genetic mutation, so it's a genetic disorder. It's rare. You can find it in 1 out of 20,000 to 40,000 live births, and 10% of cases of severe epilepsy in children will be Dravet syndrome. The clinical features will be that signs and symptoms will worsen with increased age, meaning the younger the child, the less the severity, and the older the child becomes, the worse the severity. Usually resistance to conventional anti-epileptic drugs, just like you found in Lennox-Gastaut syndrome. It starts at 12 months of life, and there will be associated developmental delay, associated with chronic infection, and poor interpersonal relationships. Still on clinical features, there will be prolonged febrile seizures or sometimes prolonged afebrile seizures to progress to myoclonic or partial seizures. Ataxia will be present, that is balance issues, and there will be obvious psychomotor delay with cognitive impairment and motor deficits. Also, there will be ADHD or hyperactivity alone. There will be behavioral deficits and autistic-like behavior, making some to make wrong diagnosis of autism in them. Insomnia will be present with sleep difficulty, and there may be somnolency. Now, the misconception about Dravet syndrome. Out there is a wrong assumption that immunizations will be responsible for Dravet syndrome. Why that? Because the first sign of Dravet syndrome will be pretty close to the time of immunization commencement. We have routine immunization schedule, right? So the first time the child will come down and be diagnosed with Dravet syndrome is about the same time that immunization will begin. Remember, it will usually start from the first 6 months to 1 year of life. But no, that is not so. It's just a coincidence. Now, the pathogenesis. The main problem here is the genetic mutation in sodium voltage gated channel alpha subunit 1 and 2 with abnormal sodium channels leading to the signals responsible for the myoclonic epilepsy form of Dravet syndrome. The mutation can lead to a reduction in the number of sodium channels. Then, the individual will come down with Dravet syndrome. Still on pathogenesis, the sodium voltage-gated channel alpha subunit 1 gene is the most important mutation as far as epilepsy is concerned. There will be a loss in sodium channel function with missense mutation in S5 or S6 segment of the sodium channel pore, causing the development of Dravet syndrome. Now, the loss of sodium voltage-gated channel can cause epilepsy and premature death in Dravet syndrome. Now, how do we make the diagnosis? The history is such that the infant will be born healthy. So the infant is healthy at birth. But by the time the child will have the first birthday celebration, the seizures would have surfaced. So the first year birthday will be with seizures disorder. Seizures would have been present. The very first seizures will be prolonged, maybe unilateral, and maybe generalized. Present also might be myoclonic seizures. The coincidence with vaccination timetable will occur. Still on diagnosis, normal developmental milestone will be the case initially, but developmental milestone will be slow later on in the first few years of life. There will be history of fever or febrile seizures, and it could be triggered by exposure to a prolonged warmth or hot temperature. Could also be triggered by bright lights. Still on diagnosis, ataxia could be part of the history and part of the signs that could be seen. There might be flat feet with ankle pronation and hypotonia. Electroencephalogram will be normal at onset, but will later show polyspikes. How do we treat? Truth be told, there is no cure, and it's very difficult to treat. We can, however, reduce the frequency of attacks. Different countries, they form variable modalities over the years. Lifelong treatment will be the case, particularly in handling the myoclonic epilepsy. Still on treatment, you can make use of benzodiazepine in acute phase. In 2018, cannabidiol was approved for Dravet syndrome treatment. Alternative treatment is using topiramate and ketogenic diet. Dravet syndrome with myoclonic epilepsy should not use sodium channel blockers. So, you cannot use the following medications: phenytoin, lamotrigine, gabapentin, or carbamazepine. We are free to choose from topiramate, clobazam, ketogenic diet, strepentol, or valproate. In Europe, they are making use of strepentol, clobazam, and valproate. Lastly, on treatment, we can make use of the services of speech pathologists for speech therapy, psychomotor therapy, cognitive rehabilitation, family counseling, and support, because it's not going to be so easy having to support a child throughout with this. If there's depression or anxiety, we have to treat appropriately in the child or the young adult or the parents that will be taking care of, or the caregivers generally. With that, I've come to the end of this very presentation. Remember to share this. Remember to subscribe to my channel so that you can get all my presentations immediately they are published. I appreciate it.